city. Yes. So allow me begin this CPD with a word of prayer. Loving Father, I want to thank you for this time that you've given us. We thank you because there is learning that is going to happen. We pray this, believing and trusting in Jesus' mighty name. Amen. Yes. So we are going to have a presentation on Ebola virus disease, the overview, the preparedness and prevention. So allow me introduce our presenter. Our presenter is a man that I love so much. I have always looked up to him. Yes, I way back. I remember when I was in second year or third year, he taught me how to do blood pressure, to take blood pressure readings. So he's a man I honor. He is an associate consultant physician. He's called Dr. Orit Daniel. Yes, he is a man who loves patience. I've seen he's a man very humble. So we are very excited to have him present to us, and it is an honor to moderate this presentation. I am the current chairperson of CPD at Uma Teso branch. So we allow me welcome him to give a presentation. You're most welcome, sir.
All right, thank you so much, Dr. Moderator, for your kind introduction. Good evening, ladies and gentlemen on call. I'm Daniel Orit, and I'll be taking you through this session on Ebola virus disease with our main focus on awareness, preparedness, and prevention. So I'll tailor my presentation on the outline displayed. We'll get to know more about Ebola virus disease, its transmission patterns, epidemiology, and current situation in Uganda, the pathogenesis, clinical manifestation, treatment options, and then we shall end with preparedness and prevention, which is our main take-home for today. So in the past few weeks, Ebola virus disease has been the main talk. And so what is it? Ebola virus disease is a serious hemorrhagic illness and is often fatal in humans. When we think of Ebola, we think of a sick person who is bleeding. But it's important to note that only half of the patients may present with bleeding from the skin, nose, mouth, also bloody diarrhea, as well as bloody vomiting. Without treatment, the mortality rate of the disease can be as high as 90%, and chances of survival increase if treatment is administered quickly. Ebola virus belongs to the Filoviridae family. 6 species do exist, although the most documented species are 5, which includes the Zaire species, Sudan species, Bundibujo, Reston, and Thai. And the newest species is called Bombali, discovered in 2018, although its virulence in humans is still not fully documented. In Uganda, we've so far had outbreaks in the past caused mainly by 2 species. That's the Sudan Ebola virus and Bundibujo virus. And Bundibujo virus disease species is responsible for the current outbreak in Uganda and the Democratic Republic of Congo. Okay. So epidemiologically, Ebola outbreaks date back to 1976 when it was first recognized and has continued occurring sporadically since 1976, with the most current outbreak ongoing in Democratic Republic of Congo and Uganda. Countries affected include the DRC that has had most of the outbreaks since 1976, West African countries like Liberia, Sierra Leone, and Guinea that had the largest outbreak in history, spanning a long duration with many cases and death. And in Uganda, we've had 8 AVD outbreaks so far since 2001. And in all these documented outbreaks, health workers have been considered high risk. Many health workers have contracted the disease, and many have died in the line of duty. Therefore, what is our CME all about? It's about creating awareness about the disease to you, the health workers. Prevention, preparedness is very key to our health worker population. And when you clearly see the displayed pictograph, you clearly see that we've had very many cases with very many deaths occurring at the same time with a high fatality rate. In Uganda, we've so far had 8 EVD outbreaks, like you can clearly see in the map displayed, with the first outbreak being caused by SVD strain, and it occurred in Gulu, spreading later to involve Masindi and Barara. And in this outbreak, we had a total of 425 cases and 224 deaths. Of the death, 22 were mainly health workers who passed on. The second occurred in Bundibujo, and that was in 2007. We had 116 cases, 39 deaths. In 2022, we also had an outbreak in Mubende Kasanda with about 164 cases, 53 deaths, and 5 health workers being involved. In 2025, we still had Ebola virus in Uganda with 19 cases, 2 deaths. 4 deaths, sorry. And the most recent, the ongoing current outbreak, as seen here, so far it's 19 total confirmed cases. We so far had 2 deaths, but what I should interest you in is the mere fact that out of the 19 confirmed cases, 5 were health workers, and the health workers contracted this virus because of laxity in our line of duty, which I'll talk about later as we talk about infection prevention and control measures. So then how does the virus spread from the reservoir to the human population to cause the outbreak? Rather looking at the transmission patterns, one possible scenario could be an infected bat hits a fruit from a hanging tree. The virus in bat saliva gets transferred to the fruits. The fruit falls to the ground and is eaten by a chimpanzee. The chimpanzee is now infected with the virus. The infected chimpanzee gets sick. And during man's activities of hunting, he comes across the sick chimpanzee, kills it, and then meat is eaten, and then we start person-to-person transmissions in humans. Or we can also have an indirect transmission whereby we have the bat picking onto these fruits, the fruits fall on the ground. Then persons within the forest pick the same fruits without washing them, they eat it, get infected, and what comes in next is the person-to-person transmission. So in terms of transmission in humans, it can be in form of a direct transmission, which is an immediate contact with infected and susceptible persons. And this could be through the body fluids like we see here. We see blood, saliva, vomit, feces, sweat, or urine from an infected person. Or it can be through indirect transmission, whereby human beings get into contact with inanimate objects like soiled clothing from the sick persons. And in this way, the transmission chain gets activated, resulting into infections in the human being. So when we fail to break the chains of transmission and the virus gains entry into the body through one of the following pathways, the following pathogenic mechanism then takes place. So why I'm taking you through this pathogenic mechanism is to enable you understand what exactly happens when Ebola virus gets into the system. So we have the virus entering the body through contact with infected blood. It attacks your immune systems and destroys the white cells. Infected cells transport the virus throughout the body. It forms clots and damages organs and also depletes the clotting agents, hence the hemorrhagic manifestation. The immune system goes into a dangerous overdrive known as the cytokine storm. The disease then can attack any other organ, including the brain, liver, kidney, and overall the vascular system damaged, internal and external bleeding from the wounds, mucous membranes, and orifices. And if at all interventions are not arrived too early, in most cases, it culminates into a death. So in summary, it has 2 main complementary and pathogenic mechanisms that make it deadly. One, it turns off the activation of the virus-specific immune response. So you get little or no antiviral immunity to control the replication of the virus inside your body. Then 2, it also turns on the inflammatory response. bringing in the cytokine storm, resulting into increased permeability, hemorrhage, shock, and ultimately death. Now, to make it simpler for you, whenever you talk about Ebola's pathogenesis, I want you to think of it in terms of a domino effect. I don't know if some of you have ever played domino as children, but when you look at where my cursor is, domino was simply a set of tiles. And when you look at it, it has this pattern in that when one of the tiles falls down, the rest will continuously fall. So what exactly happened is that a domino effect is a cumulative chain reaction where a single event triggers a sequence of similar or related events, and the time between successive events is relatively short. So it illustrates how one trigger mechanism, which in this case is infecting the immune cells, is going to trigger a cascade of events that is going to culminate into the consequences that we see in Ebola virus disease. Like when you look at this pictorial, you clearly see that it infects the immune cells as the initial trigger. You have a cytokine storm coming in with massive release of pro-inflammatory cytokines. Viral replication occurs in cells, which it gets escalated. Then we have production of interferon gamma and maturation of dendritic cells are inhibited. Now remember, these are anti-inflammatory cytokines which are inhibited. Once this is inhibited, then your body cannot fight the inflammatory process that gets on. You have also this activation of T and B cells being inhibited, so your body cannot fight back. The virus continues to replicate unchecked as vesicular permeability increases, spreads to other cell types, especially the liver, which fails. And as a result of this chain reaction, we have death coming in from vascular shock and hemorrhaging. So what does this mean to us health workers is to try as much as possible to avert or prevent this cascade from taking place in our bodies or in our other person's systems, especially our patients. So how can we do this? Through prevention practices, which I'll repeatedly emphasize in this session, because once we get careless and allow ourselves contract a disease, there may be no means to stop the cascade of the preceding events. And clearly remember, prevention is better than cure. So you rather prevent the disease than it happening in you and you try to stop a domino effect, which in most cases tends to be irreversible. So the consequences of a domino effect manifest as symptoms and signs and complication of the disease. That is the clinical progression, as we shall see in the subsequent slides. So what exactly happens is that a person gets infected with a virus, as the photo shows. The person may have been infected while caring for someone who is sick or has died of Ebola, or it could be a health worker during your line of duty and you get into contact with body fluids from the sick patient. Then once the person is infected with the virus, the incubation period begins. Incubation period in most cases can last between 2 to 21 days, but usually it's 4 to 17 days. And the infected person in this case is not sick, does not show any signs of illness, and the person cannot transmit the virus at this time during the incubation period. Then as the disease progresses, we get into the dry symptoms. And during the dry phase, the patient with Ebola disease generally have an abrupt onset of fever and symptoms 8 to 10 days after exposure. These dry initial symptoms and signs and symptoms are non-specific and may include fever, fatigue, headache, joint pain, muscle pain, back pain, or even a sore throat. With the onset of symptoms, the infected person is now contagious and can transmit the virus to others. Then 4 to 5 days after the symptom onset, the patient progresses to the wet phase as characterized by gastrointestinal symptoms, which include severe water diarrhea, nausea, vomiting. Bleeding may occur in some cases. The patient may get hiccups and eye redness. As the disease progresses, some patients may develop bleeding and hiccups. This person is very contagious and all the body fluids are contaminated with the virus. Bleeding is not universally present. However, it can manifest later in the course of disease as petechiae, ecchymosis, or oozing from venipuncture sites, mucosal hemorrhages of blood in stool or vomitus. In general, unexplained bleeding is reported in 40% of the patients, and the patient is more contagious as the disease progresses. In fatal cases, Death occurs on average 7 to 10 days after onset of symptoms, and the amount of virus is highest at these stages. Okay, so after having looked at the clinical progression of disease, I want to bring your attention to the phases of illness. And in summary, EVD patients manifest with different signs and symptoms per the phase of illness. During the early febrile stage between day 0 to 3, it's mainly a fever, malaise, fatigue, and body aches. Now, the take home that you must know here is that when you look at most of these manifestations, especially in the early stages, 0 to 3 days, 3 to 10 days, these are manifestations that can occur in other diseases or illnesses that patients come with to the hospital. And what this clearly tells us is that we must always have a high index of suspicion right from the beginning, because you never know the patient that you're handling could be having an Ebola. And in most cases, during the early phases, patients may not really seek healthcare in the facility. A majority of them may take homemade remedies or to be able to manage fever and fatigue and body aches. And then during the gastrointestinal phase, most may seek medical attention at the facilities, or for those who believe in shrines, they'll prefer getting into shrines. Now, because the common manifestation with other illness, this stage comes with always a missed opportunity by clinicians if history is not fully taken, or in clinicians who always have low index of suspicion. So this stage has been attributed to high transmission phases amongst health workers. And unless we, the health workers, have the culture of universal safety precautions and IPC, adherence to IPC, like we shall see later, a majority of health workers actually get infected during this stage, because a patient comes to your facility, you have a low index of suspicion, thinking the patient could be having malaria or gastroenteritis. You get careless in handling this patient, and in the long run, when the patient progresses to hemorrhagic manifestation, it finds you cannot reverse back the contact that you had with this patient's secretions. So the take home is clinicians always have a high index of suspicion. History taking should be so good to be able to clearly identify who these cases are, so that we all prevent ourselves from getting Ebola disease. So between 7 to 12 days, as the disease progresses further, this is now a very sick patient, gets into shock, and this is when most clinicians wake up and start asking questions. The patient that I treated is not improving. Could this be a hemorrhagic fever? But remember, when you get into these phases, you've already come into contact with these patients, especially if your IPC practices were not adequate. So my take home in this particular slide is always have a high index of suspicion when you're handling this patient, adhere to universal safety precautions, and always practice your IPC practices, like we shall see in the slides on prevention and preparedness. So this slide, I simply wanted to show you the common clinical manifestation in EVD patients. We see a majority will have a fever, which commonly occur with other illnesses. Fatigue commonly occurs in other illnesses like malaria. We live in a malaria endemic area, so most of these patients are mistaken and having malaria. Then we also see that GI manifestations. In our setting, a majority of patients will come presenting with vomiting, diarrhea, anorexia, abdominal pain, which is still a manifestation in, similar to other diseases. So by looking at this slide, it clearly tells you that as we talk about Ebola, having a high index of suspicion remains the key pattern in being able to prevent you from getting into contact with the patient's body fluids. Putting IPC practices in place will go a long way in preventing you from catching the disease. So rather, the differential diagnoses that we look at that may tend to mimic, clearly here we see malaria. It's one of the common diagnoses that we make in our facilities. Typhoid fever, majority of us have made that diagnosis, and clearly its symptoms mimic those of Ebola. We've seen shigellosis, bacillary dysentery. Hepatitis commonly occurs in Eastern region. We have a majority of patients having hepatitis. And there'll be situations whereby a patient comes in and is vomiting blood. And remember, because you've seen quite a number of hepatitis patients, you're going to assume this is a complication of liver cirrhosis. Yet in actual sense, your patient has Ebola virus disease. So what does this mean? That this is a clarion call for all clinicians to, one, take a full history. Let's get back to the standard way of coming up with a diagnosis, like we used to do when we're in medical school. However, majority of us, when we leave medical school, we lose out on the adequate history taking and prefer seeing patients with basic symptoms, and we do not take a full history. Then also remember that 90% of your diagnosis is done on history. So I'll emphasize that for you to be able to differentiate between the very many differentials of EVD, we need to get back to our full history taking. Then two, we also need to use a case definition. We need to be able to improve on how we probe our patients, especially probing the epidemiological links to disease, like I'll show you in the next slide. And key in all this is always try to have a high index of suspicion, utilize the case definition protocols as spelled out by the CDC or WHO. So what is a case definition? This is what we mean by a case definition. For Ebola virus disease, the Ministry of Health, through CDC and World Health Organization, came up with these case definitions to be able to help clinicians be able to make a quick diagnosis for patients who we think could be having Ebola virus disease. So in your daily clerkship history taking of patients with complaints similar to EVD, use a case definition to narrow your index of suspicion. So for the case of a VHT, because there'll be situations whereby we work with the village health teams or community persons, their case definition for Ebola is not so complicated. It's simply illness with onset of fever or no response to treatment, or at least one of the following symptoms: signs, bleeding from the nose or other part of the body, bloody diarrhea, blood in urine, or a sudden death. This has been made so simple because in most cases, the village health teams may not necessarily be clinicians. So what we want is for them to be able to identify as many as possible cases in the community, refer them to the health facility, and in the health facility where you, the clinician, sit, you now come with definite case definitions. So in case definitions for your suspects, I need to mute. Okay, sorry for that. I had to mute that person. Okay, so for the clinicians, the case definitions that you'll have to use will be knowing who a suspect is. And suspect one is an illness with onset of fever or a negative lab diagnosis for usual causes of fever and at least 3 of the following symptoms as listed here. For a suspect 2, it's any person with a history of fever and at least the following: history of contact with a suspect probable or confirmed Ebola case, history of travel to an area with a confirmed outbreak of Ebola, unexplained bleeding or unexplained death. So what this brings out is the epidemiological link that you clearly see that we talked about. So whenever you have a patient that you suspect to be having Ebola, it's very key that you use the case definitions, and this will help you to narrow down the diagnosis. Also, what it will help you with is not to turn away patients who actually do not have Ebola, because one thing that we've clearly seen is that now that the Ebola talk is rife, you find a majority of patients who present with symptoms that a majority says the clinicians tend to fear them, and in this case, we tend to delay their treatment, and this could lead to complications. So by using a case definition, you're able to narrow this into knowing that, okay, does this patient fully meet my case definition for an Ebola case, or it does not meet, and I can continue with the normal treatment for this kind of patient. So take-home message here is whenever you're clerking this patient, just ensure that you have case definition leaflets on your table and spread the gospel. Talk to all the other clinicians who get to interface with the patients to always use a case definition in clerking their patients to be able to come up with a narrow differential diagnosis for Ebola virus disease. So once you suspect EVD and you have an EVD suspect in your facility, we need to confirm using the labs. So the following labs can be used depending on the timeline of infection. So we see that within a few days after symptoms begin, the diagnostic test available could be ELISA, IgM ELISA, PCR, and virus isolation. Later in the disease or course after recovery, IgM and IgG antibodies tests. Then in case we need to do it prospectively in deceased patients, you can use immunohistochemistry testing, PCR, and viral isolation. However, out of all these, PCR is the gold standard. And to bring your attention is that Ebola virus disease is detected in blood only after onset of symptoms, most notably fever. There'll also be situations whereby you're going to get a negative test, especially in patients with symptoms less than 3 days. So what is recommended is to repeat the tests at 72 or more hours after onset of symptoms, and keep patients in suspect area until a sample is taken 72 hours after symptoms begin is negative. But key to this is just know that the test available in Uganda actually is the PCR that we use for testing. So once you confirm EVD, we need to treat these patients. Treatment should be always in an isolated unit designated as Ebola treatment units. There's no defined medication or approved therapy specific for Ebola treatment. Our treatment is predominantly supportive and focuses on underlying complications and manifestations. Patients often present with volume depletion. So when you're doing the supportive management, always look out for aggressively replacing the volume loss. Oral rehydration salts, especially if the patient is ceased vomiting. IV resuscitation will be the best in this case. Because they get into electrolyte imbalances, always replace their potassium and magnesium. They also get into hypoglycemia because remember, when we looked at the pathogenesis, somehow the liver gets affected in the long run. And remember from our basic biochemistry, our basic physiologic sessions, you clearly remember the glycogenic processes taking place in the liver. So in this case, most of these patients are predisposed to getting hypoglycemia. Our patients will also have co-infections with bacterial infections. So we manage them accordingly with appropriate antibiotics. Assess their nutrition status and treat them accordingly. Encourage early enteronutrition. And because they're also prone to getting stress ulcers, it's advisable to use prophylaxis using proton pump inhibitors for such patients. Sorry about that. So other complications that these patients will have. However, this is dependent on the patients. Patients will come on different case-by-case basis. There'll be those patients who will have different manifestations, and this is how you'll treat them. Remember, this treatment is mainly symptomatic. Like we said, we do not have specific support. Try to treat the disease. Sorry, I need to mute. Okay, so in case your patient has a fever and pain, of course, you'll use paracetamol. Avoid using NSAID in this case because we have a concern for thrombocytopenia and bleeding. Okay, so for the case of opioids, caution should be in hypertensive patients as they may reduce gut transit in diarrhea. For the case of nausea and vomiting, promethazine. Diarrhea, this is what you can do. Dyspepsia, agitation, malaria, bacterial co-infections, and gut translocation. So the World Health Organization recommends these guidelines that we must always adhere to. Key in them is the systemic assessment and reassessment of all Ebola patients. So if you have a patient admitted in the isolation unit, the ETU, When we say systematic assessment and reassessment, what is recommended is the staffing ratio should be of 1 clinician for 4 patients. Assessments should be done for each patient and performed at least 3 times per 24 hours. So you clearly see the contact time that you're going to have with this patient is really much. And in all these contacts that you're having with this patient, you may be unlucky and you contract the Ebola virus, especially if you've not adhered to IPC. You need to do close monitoring of the patient to allow recognition of reactions and acute changes in condition, identification of patients in high risk for complications. And the main priority in all this is whenever this happens in your health facility, because I want to believe in this call, we have varied health workers coming from different health facilities. You're the managers of the health facilities, the heads of departments. And in case Ebola happens in your facility, do not treat them in the main ward. Have a designated isolation unit that you're going to designate as an Ebola treatment unit. And this is where all the supportive management will be done. This, in most cases, is done in the early days before Ministry of Health actually takes over and transports this patient to the main ETU at Mulago. So what this looks at is within those few time when you're still with this patient, do not ignore this patient. Give them supportive management as you await for transportation to the main ETUs. Fluid resuscitation is key because most of these patients are dehydrated. Electrolytes monitoring and correction, glucose monitoring, they get into hypoglycemia. They may get potential co-infections, treat, nutrition, symptomatic care and prevention of complications, as well as management of complications in this patient. So what you see here is a WHO daily assessment checklist. We shall be able to circulate this to you when we circulate the slides. So what this entails is that just in case you have an isolation unit or an ET unit at your facility, this is what you need to do on a daily for these patients before they are transferred to the ETU, the main ETU at Mulago. So ladies and gentlemen, we now all appreciate that EVD is a lethal disease. We as health workers are at a high risk of contracting disease because the nature of our work. A domino effect kind of pathogenesis where we may fail to reverse complications and no therapy specific to EVD is the main thing that you've seen in the slides that we presented before. So our next slide is the key takeaway for our CME tonight. In our next slides, we're going to look at EVD prevention and preparation. So if there's anything that you can take away from my presentation this evening, ladies and gentlemen, it's you understanding the prevention and preparedness. Like I told you, prevention is better than cure. You've looked at how Ebola gets into the system, its pathogenesis, putting into consideration the domino effect that in most cases is reversible. And one initial triggers brings in a chain of reaction that in most cases leads to disastrous complications and death. So the key thing here is for all clinicians, prevention is the key thing when we are in our line of duty, because we can't avoid contracting Ebola, especially if we're in our line of duty. But if you put IPC guidelines into place, as well as adhering to universal safety precautions, then we shall be able to avert getting the disease. So in my preamble, allow us recap on the transmission tree for Ebola. So clearly we see a patient, 2-year-old child, somewhere gets into the forest, picks a mango that was eaten in the bark, contracts Ebola. Of course, as a mother to the patient, mother gets a concerned care takes for this child and brings the child to the health facility. I'll focus so much on how we health workers really get exposed, because innocently during our line of duty, we get to interface with most of these patients. We do not know where they've actually been. We do not know what diseases they have. We interface with them. We're careless in our practices, especially IPC practices. We fail to follow the universal safety precautions, and the next thing you know, a majority of health workers get affected just because of one case of this child getting infected. We have a health worker here who did not pay attention, infects the rest of the health workers, and what you know is your family also gets into the mix. So you clearly see that even in the different death that we saw in the previous slide that I projected, the death that we saw in Gulu, Lacho, the death that we saw in Bundibujo, what happened in Mubende, Kasanda, the 5 health workers who are currently in isolation unit at Mulago, all this happened because during their daily routine, they failed to uphold to the universal safety precautions. And there was a breach in the IPC protocols, like we shall discuss in the subsequent slides. So in all that you think for the remaining bits of these slides, think about the carelessness that happened when these health workers contacted the patient with Ebola and turned out to infect the rest of the persons. So who is at most risk of getting Ebola? You clearly see it's health workers, and these health practitioners as well as senior practitioners, the vets, then our families come into place because somehow we have to interact with our families. Our families do offer us care when we're sick. So from just one person who did not adhere to the universal precautions, you clearly see that a number of persons get affected. So what this means is that prevention is better than cure, like I'll re-emphasize. And the onus is on us health workers to prevent getting infection through having a preparedness and prevention plan at our facilities, like you see this displayed. And since by default we are managers of our respective departments and facilities and daily routine work, we have to ensure that in all that we do, in the places that we are placed as managers or even health workers, we should be able to come up with a preparedness plan. So what is an EVD preparedness plan? It focuses on early detection through VHS surveillance systems, like we shall see in the subsequent slides. Infection control precautions, very key to us as health workers. Health promotion by talking to the community about the dangers of disease and how to identify cases and prevent close contact. For the vet individuals, collaboration with animal health services, early warning, all this should be done. Then we also have alert in our preparedness, which entails epidemiological investigations. Then in the control, once all these fail, these two fail, then we come to isolation units and case management. So what we're simply looking at here is the primary prevention of disease, and this is the secondary prevention. Secondary prevention, the disease has occurred and we can't do much. We just have to manage the patients who get into the isolation unit. But my main focus and take home for everyone on call will mainly be on infection control as well as VHF surveillance. So to talk more about IPC, I want you to look at this displayed pictograph. We clearly see that we have a chain of infection and control. And for any IPC practice to work, you really need to understand the chain of infection. Chain of infection is simply a series of events that must occur for infections to spread. And this is known the chain of infection. There are the 6 steps or links in the chain. And what we see here is we have a susceptible host, an infected individual after the infectious agent enters their body. Then we have the infectious agent here in the individual. We have a reservoir. From the reservoir, we have portals of entry, the modes of transmission, and portals of exit. So in case we want to break the chains of transmission or prevent the disease from spreading or persons from getting infected, we have to break these chains of transmission. And how do we break these chains of transmission is simply by looking at universal safety precautions as well as IPC guidelines. Like when you look at this pictorial, you clearly see the chains have been broken. And how the chains have been broken is by looking at practices like hand-eye hygiene, which lies in your IPC, aseptic techniques, still hand hygiene, sterilization, disinfection, and all these are IPC practices that you can put into place to be able to break the chains of transmission. Once you break the chains of transmission, then we're able to control the disease and we do not have people getting infected. So what does that mean is to follow what has been displayed to you. So when you look at this display, You find that hospital acquired infections to health workers happen because we do not adhere to the above concepts. I want you guys to take a few seconds to just read of universal health precaution emphasizes that all our patients should and can infect the caring health worker. When you look at what happened in Lacho, this concept was broken. What happened in Bundibujo, 14 health workers dead, concept was because the concept was broken. The 5 health workers in Mubende outbreak, concept was broken. The 5 health workers currently infected and isolated at the ETU, concept was broken. What this concept entails is that even if it's your parent, it's your loved one, your child, consider them as a potential threat to having a blood-borne pathogen when they get into the hospital. Because we've seen situations whereby your fellow health worker comes to the hospital, is presenting with signs and symptoms. It could be any other disease, but because you're used to this person, in your mind, you're like, but this is my health worker. Why must I put on gloves when I'm touching this patient? Same applies to your closest relative. You have your mother coming into the facility. She's oozing blood, vomiting and coughing. The gloves are far away. What you're going to do, instincts will clearly tell you, I need to save my mother. I need to save my child. I need to save my friend. You're going to jump in, touch the patient without putting on personal protective equipment. And in the long run, you clearly see you've 100% exposed yourself to the disease. So the key emphasis, my colleagues in practice, is ensure that in whatever you do on a daily basis when you're in a health facility or when you're called out anywhere, put in the concept of a universal health precaution. Everyone has potential to infect you. Look at it, try to be a little selfish. A majority of us do not get selfish when it comes to this. We want to be the saviors, and yet in actual sense, we're infecting ourselves. So in all that you do, picture the different health workers like I've displayed here, of how they got into contact with the body fluids. And the next thing that resulted was them contracting the disease. The unlucky health workers, of course, lost their lives. And there are those that got recovered. But I'm 100% sure the consequences that they went through is not something nice that you can really want to have in your life. So what this means, therefore, is you need to put IPC practices into play. And through IPC practices, you're able to protect yourself, protect your community, and protect your patients. How you protect yourself, universal safety precautions, and follow the IPC guidelines by hand hygiene, appropriate PPE, cleaning and disinfection of affected surfaces, proper waste disposal, decontamination, and reprocessing of reused tools. Why you need to protect the community, you've seen situations whereby we have poor waste disposal. For all the waste that come in the hospital, you go and throw them into the common public waste bins. What is going to happen is that you're going to have individuals come to rummage through these wastes, and they'll get into contact with the blood, body fluids of sick patients in the hospital. So as a clinician, the onus is on you. Much as you're going to be selfish with yourself in following universal safety precautions, ensure that you also protect your community and protect the patients. In protecting the patients, we've seen situations whereby, because we do not have gloves in the hospital or we are lazy at wearing these gloves, okay, let me use stethoscopes, because a majority of us, when we use stethoscopes on one patient, it's on rare occasions that you actually get to clean up the stethoscope, and you're going to use the same stethoscope on the next patient without gloves. So my fellow clinicians, still it gets back to you. As you protect yourself, look at the community, look at the patients. Because at the end of it all, if you protect yourselves and these two are not protected, still the chain of transmission gets back to you. It could be your relative being affected somewhere else because you did not pay attention to protecting these individuals who involve your patients and the community. So I'll keep on re-emphasizing Through IPC practices, we can prevent EVD in our region and country. So let's readopt all our IPC practices like we were doing during the COVID outbreak. Okay, sorry. So in our next slide, we shall look at EVD surveillance systems. And remember that with IPC practices in place, our next step is preparedness pillar of surveillance, because early recognition is critical for infection control. So what should we do when we're at our health facilities? After we've put IPC practices in place, you're going to encounter these patients, because we all have screening areas in the hospitals or health facilities. And you're going to have these patients come in your clerk room, in your clinical rooms. So what we emphasize in EVD surveillance is the first step is to initiate. In initiating, think Ebola when you approach a patient and start the steps for basic infection control before assessing the patients for risk. Always use standard precautions as you're interfacing with these patients. If there are any concerns that the patient could meet the criteria for Ebola, immediately separate the patient from others. You're going to do the aspect of isolating. Then the next step is to identify. So you assess your patients for travel to a country with widespread transmission or contact with someone with Ebola within the last 21 days and has any of those signs. Rather, you're using a case definition here when you're talking to this patient that you highly suspect could be having Ebola, because you want to narrow your index of suspicion and diagnosis to a patient who truly has Ebola and not other patients who could be having other to isolate. So if there's action, isolate the patient in a private room with a private bathroom or covered bedside, commode and closed door. Wear appropriate PPE, limit healthcare personnel who enter the room. PPE is because this could turn out to be contacts later on if the person turns out to be positive, and only perform. You highly suspect this patient could be having Ebola. You've drawn their blood samples and you're waiting for results from the central lab to be able to confirm if it's an EVD case or not an EVD case. So once it's confirmed as an EVD case, alert others, including public health officials. Notify your facility infection control, contact your state or local, as well as contact the responsible persons in your health facility, as well as the district. Because by now, there's been reactivation of rapid response teams, and these are the individuals that you can contact to be able to help us in being able to control the disease. This summarizes what we just discussed, and when you look at this algorithm, it's one thing that you can adopt in your facilities. In the first, identify exposure history. If it's a no, continue with the usual triage and assessment. So this is a patient who, from your history taking, clearly does not fall in the line of being an Ebola suspect. You do not want to deny them care. You want to continue caring for them, and you're going to continue with the usual triage and assessment. However, if it turns out to be a yes, identify signs and symptoms. Then if it's a yes, isolate, put on PPE, and follow the next procedure. So it's more like a repeat of what we just discussed. The same applies to this. In your health facilities, you can actually adopt this chart. It makes it easy for you to be able to use this as a checklist for the patients that will come to your facility, especially when you're screening for them. This can also be shared with the nursing team or the persons at the gate, because what I know right now in most facilities, because of the Ebola outbreak, you find gears have been placed, everything has been placed on a high gear to be able to adhere to screening protocols. So we can just adopt this chart to be able to give us a directed pathway for identifying who an Ebola suspect is and those who are not. So here I show you what a preparedness checklist looks like. This was adopted in one of the health facility in Mukono. And when you look at their health facility and staff preparedness checklists, during one of their meetings, so we have staff training and knowledge. In staff training and knowledge, identified persons were able to give talk to the health workers within that facility about adhere to IPC guidelines. The patient flow in the isolation unit, which occupational health and safety, and this mainly focuses on occupational hazards that may occur in the facility. If a health worker gets exposed, what pathways must we follow? Then they also had to look at securing essential supplies and commodities. And this part here is very key in that you need to have adequate commodities to be able to run your facilities. Because put yourself in a situation whereby Ebola has happened in your facility and you definitely will not be able to touch patients. So ensure that you have essential supplies and logistics to be able to support in case you have an Ebola outbreak happening in your facility, or even as a preventive measures to be able to use these PPEs on a daily basis. So in summary, we need preparedness to control in outbreaks in our region and country. And if we have all this, putting major emphasis on the surveillance